Hello, thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University in Brisbane, downtown Brisbane, and today we're very fortunate to be joined by Professor Filip Rob, who's the head of the Dermatovenereology department at the Second Faculty of Medicine, Charles University, University Hospital Bulovka in Prague in the Czech Republic. It's a pleasure to have you to join us today, Filip, to discuss your recent paper published in the International Journal of Dermatology, which looks at the efficacy, safety, and drug survival during the first year of biologic therapy for psoriasis, and it's a comparison of elderly versus younger patients. So welcome, Filip. Can you tell us a little bit about yourself and where you work and what your interests are?
Hello, everybody. Thank you very much for the invitation. I'm living in Prague, Czech Republic, so in the middle of Europe. I'm a dermatologist for over 13 years. For last 3 years, I'm a chair of our university department. And my research is mostly based on psoriasis and modern treatments and more like patient-centered outcomes. And recently as well, like atopic dermatitis. But based on my research, we try to search what are the gaps in like common practice when we treat our patients, and when we thought that the elderly are one of the gaps still problematic for a lot of the not only patients but as well the physicians, how we handle these patients.
Excellent. So could you just fill us a little bit in on what the biologic scene is like for dermatologists in Prague? Is it easy to access? Is there difficulties getting various therapies? And do they have to fail a number of drugs before they're eligible? And who pays for the biologic?
Yes, definitely you're right. We have like only public health insurance. So there are like general rules that apply for everybody. That are different for like adults and children, but in adults it's the same. For example, in psoriasis, you must have like severe psoriasis, so PASI over 10, and then you have to fail at least 2 systemic treatments like methotrexate, cyclosporin, acitretin, or phototherapy, and then you are eligible for like the biologic treatment. Fortunately, we don't need to start only with the TNF-alpha blockers or the biosimilar drugs, the cheap drugs. So when the patient has these 2 systemic treatments, we can choose any biologic treatment we wish, to be honest. So they can be an effective treatment. Sorry.
Okay. And this particular study we're going to talk about comes from the Czech registry. Can you tell us a bit about that registry? Is it compulsory? Does everybody go in it? Is it voluntary? How do you get that data together?
Yeah, it's voluntary registry, but we are fortunate that the physicians who are in Czech Republic, we only can prescribe the treatment on like centers. So we have like 50 centers all around the Czech Republic. So everybody, like 95% of the centers are involved in the registry, and the physicians are trying to help with the research. So I think most of the patients, about 90+% of the patients on biologic treatments are in these registries, even it's voluntary. So the Czech patients are very nice that they agree that we are able to collect these data of these patients, which gives us like quite a lot of knowledge about these patients, not only when we speak with the health insurance companies, etc., that we want to change something or give the patients more options, as well for like the research purposes.
And this particular registry looks at both efficacy and safety. It records disease activity and all that stuff. There's quite a long list of things that you record.
Yeah, that's true. We record some like the baseline information about the patients, the previous history of the treatment of the disease, as well the comorbidities of these patients. And every visit is usually every 3 months at the start of the treatment, and every 6 months we fill in the registry how the patient is going. For example, in psoriasis, we enter the PASI score, the BSA score, the DLQI score. We write there the treatment, whether the treatment has changed or is it still the same, whether are there any complications, whether are there any comorbidities, whether is there like new medication. So it's quite extensive. So it sometimes takes quite a lot of time to pull everything into the registry, because it's not a part of the hospital IT system. So you need to go there and manually enter all these informations about these patients from each visit you record.
I'm very impressed that you've got over 90% with a voluntary system. That's excellent. So this particular paper, tell us the reason why you did it and what was the methods you used.
Mm-hmm. So basically, we choose this topic because there are many new centers who are starting with the biologics mostly, and usually they are quite scared to treat elderly patients because the main problem is there are not many clinical studies. If you check the clinical studies across all biologic treatments, like usually the inclusion criteria is up to age of 65. Very few of them have like elderly included in these studies. So you are just missing these patients in these clinical studies. So when you want to treat these patients in clinical practice, you now looking, okay, I have elderly with many comorbidities, and I have no data from clinical studies how I should handle them, or if the treatment is effective and safe for them as for the younger patients or healthier patients. So I think in the last 5-6 years, there are like a lot of more data from real world trying to show that we don't need to be scared, that we can treat as well these patients. So that was the main reason why we say, okay, we should do it. We have like robust data from the BioRep registry. So we have a lot of patients, a lot of elderly patients in this registry. So we can try to do something and get more knowledge. Because there are studies, usually they are comparing like elderly in some like registries or like multicentric trials, real world, with like younger patients. And usually these patients didn't match with like type of biologic directly or line of treatment of the biologic and other things. So it can sometimes be like misleading. So we said, okay, so we will do this study and we will do the controls, and we try to be the controls as much similar to the elderly as possible. So we choose the patients with the same gender, same treatment line, same biologic treatment, so they can be as close to as possible. And because for the adverse events, we know that for the registries, some of the physicians, for example, report everything. Some of the physicians report only very only severe conditions. So we don't want to bias this thing. So we said, okay, but these patients and the controls need to be from the same department, so the same physician. So we have the coherency as well in the adverse events reporting. So the patient, the elderly patient, and the two controls needed to be from the same department. So we gathered, I think, quite a lot of these patients, despite all of these criteria, to be able to do such a study.
So you took a couple of hundred patients, elderly over 65 or over 60?
Yeah. So their criteria was to start the biologic treatment after the age of 65. They can, for example, switch to other therapy, but we do not include patients, for example, who started in their 60s and continued. So we only looked on the patients 65 and higher at the start of the therapy.
So starting over 65, you had two active controls. And if we look at the demographics in Table 1, some of them had it's very, very long history of disease. Like in the elderly group, 31 average years of psoriasis duration. And even in the younger patients, 24 years of disease. I'm amazed that they weren't on a biologic much earlier, although a lot of them had previous biologic therapy. So how do you account for all that biologic therapy and then they're starting again?
Yeah, that's right. I think you touch a very interesting thing, that even when you look on the registries data, it shows that we are still like, there should be like decades to the patient is able to get the biologic treatments. I think we are not looking on this thing the right way. The problem is we are looking when you have the first sign of psoriasis. Most of the patients will start in their, for example, 20s, and they have small plaque on their elbow, and they don't care. So that's why when they get severe, it's like 20 years of the disease. I think we should more look like, even for the clinical trials and the real world data, to count for like the first like severe exacerbation of the disease will be much better thing that we should focus, because if we recount this for like the first severe flare of psoriasis, it will be much more like better data to see if we are really treating these patients early, or if these patients are like I'm with very mild psoriasis for 15 years, and then I have the flare of severe. But if you look at it, it's like seems like I don't have any treatment for 20 years of psoriasis. That's not true. I think that's reflecting as well in this study that most of the patients will tell you, oh, I didn't have like problem with psoriasis for many years, and then last 3 years I have like very severe psoriasis, so I went to the physician to give me any treatment. So that can be a little bit, I think, misleading in these data.
And again, in table 1, over 90% of patients were on systemic therapy. So that would have been methotrexate and other medications. Yeah. Did you account for that when you looked at your results? What concomitant medications had an effect on efficacy and safety?
Yeah, that's important thing. We were able to when all these patients started the biologics, it was only on the monotherapy. So the methotrexate and these drugs were previously. That's because it's the inclusion criteria for biologic treatment for psoriasis. So at the start of the biologic, everyone was only on the biologic without a concomitant immunosuppressive treatment. To be honest, we are not able to 100% be sure. Some of the patients, I think, will get some methotrexate or other systemic treatment together with the biologic, for example, for like flare of psoriatic arthritis. So that's really one of the theoretical limitations of our study, that some of the patients may start other immunosuppressive treatment during the observed period, and we are not getting this information. But from our registry, we know that it's approximately 10% in Czech Republic, so it's not like a high number of patients throughout the study.
And the reason for the previous biologic therapy in 40+%, and then they're starting a new one?
Yeah, for most of the patients, it was the failure of the biologics. It can be both from the stand of the plaque psoriasis on the skin, as well as some of the patients need to switch the treatment, not because they are not doing well with the skin, but their joints get worse. So that well maybe one of the reasons why the patients change their previous treatments. So there can be multiple reasons. Only small proportion of the patients were because of the adverse events, to be honest.
Okay, so, baseline PASI of about 16, so they had reasonably severe rash. Interestingly, of the prior biologics, I was interested in the ones that mostly these patients were on. Humira was only, adalimumab was only about 9%, 6% of Premolast, 11% of Tanaset, which I wouldn't have thought would have been a psoriasis-type drug, 10% in Flix, 13% ixekizumab was 17, but 6% secukinumab, and 12% risankizumab, but only less than 1% guselkumab. So it's all very interesting how the choices that people make going through different biologics when you can have open access to whatever you like. So tell us about the primary endpoint and what your results showed.
Okay. So the primary outpoint of our study, and we tried to look at the, first of all, was the efficacy of the treatment. So we think that the PASI under 2 is the treatment goal we should be trying to achieve. So the PASI under 2 was our outcome after 14 weeks, because some of the drugs have label of checkup visit after 3 months, some of the after 4 months. So most of the patients will come around the 14 weeks. Then after half a year, and then after the year. So that was the primary efficacy outcome. And then the second one, the safety, was the adverse event. If there are any like difference on the adverse events reported in the registry between all elderly and younger patients. And when we look at the primary endpoints, the efficacy was quite similar for the PASI under the 2, but even when we look on the other like outcomes like PASI 75, PASI 90, etc., it was as well quite similar. There wasn't really difference in efficacy, so that's one of the things. But that was already reported that's real. That the elderly patients don't have problem with the efficacy of the drug. It's the same as the younger patients. What was more interesting for us, that as well the adverse events reported in the registry, which for sure has some limitations, because when you get these data, some of the physicians may not report everything, were the same, 40% for elderly as well the younger patients. there was not a high difference between the severe adverse events. It was 5% in elderly and 3% in younger patients. But the interesting part was that the drug survival was lower in the elderly patients compared to younger patients. And I think that's going to the main point of our study, that despite the safety profile seems to be very similar for elderly and younger patients, we are probably, as a physician, more keen to stop the treatment after the adverse events occurs in these elderly, because we are more scared than the patients at risk at something as like this. So that's, I think, the main outpoint of our study, that it's probably because of the physician's decisions.
I'm not used to a PASI less than 2, but we're certainly used to PASI 75 and PASI 100. And a pretty impressive 30% PASI 100 at 14 weeks is pretty impressive. And out to 26 weeks, 40%, 52 weeks, 40-odd% with PASI 100. So that's pretty impressive. As you say, the safety was different, but really only 12% of the elderly discontinued. And in psoriatic arthritis land, there's much more churn over 12 months than 12%. It's getting closer to 40 to 50% have switched off their biologic, compared to you guys with skin disease. So even 12% discontinuation was pretty low, and you had drug survivals over 90%, very impressive for us, with only 10% in the elderly being due to loss of efficacy compared to 4% in the younger group. And these already failed the biologic once, 40% of them, so they were already a kind of a difficult patient population to treat. But I think very important, the adverse effects really were less than we would have considered in the elderly population. Infection, 1.5%, 1% in the young. Loss of efficacy, only 10% versus 4%. And the SAE that led to discontinuation, 1.7% versus 0.4%. So really quite impressive safety in an elderly population, and very impressive safety, I would have thought. So anything else about the results, either safety or efficacy, that you want to point out?
There was a small difference for like TNF-alpha blockers that were used to the main problematic drug for the elderly. There was like significant difference that on adalimumab the patients discontinued the treatment much more commonly than for the younger patients, and that was not the case for the other IL-23, IL-17 blockers. So there may be something about this. This as well, the problem that the older label for like TNF-alphas and adalimumab was that when there is like the severe heart failure, that you need to stop the treatment. So this is probably a part of patients that needs to be stopped, because it's quite common in elderly. But you have a quite nice point about the rheumatoid psoriatic arthritis studies. I think it's much more because you need to treat these elderly patients with like much more combinations treatments. Am I right? So when we treat them only with the monotherapy, with the biologics, it's quite safe. It seems to be compared and much more tolerated for the patients than if you need to give the systemic drugs. And I think we see it because most of the adverse events, even in the rheumatologic studies, because of the combination therapy, are caused by the conventional systemics, I think, more than the biologics itself.
And you do make the point that one of the limitations was individual biologics had reasonably small numbers to make conclusions about which was safer than the other. Is there anything that you can comment about which biologics are a little more safer than the others and which were problematic?
No, so I think the TNF-alphas show that there are maybe some problems. Generally, from the adverse effects, it seems like the IL-23, because they're quite good safety profiles, looked very well. We were a little bit scared about if there are if there are more mycotic infections in IL-17 blockers in elderly, but that wasn't the problem. So we were a little bit surprised that even in these patients, which may be a little bit more prone because of the immunosenescence to be prone to infectious diseases, that was not the case. To be honest, there were not the patients on bimekizumab yet. I think the bimekizumab may have like different story than the other treatments. And when you touch on the point of the etanercept, yeah, there were quite a lot of the patients of etanercept. If you look on the younger patients, generally in the registry and elder patients, the distribution of the drugs it's quite different. Etanercept a few years ago, before like IL-23 were available, was, I think, the main choice for a lot of the physicians and in elderly patients to start a treatment when they choose from TNF alphas. They try to avoid infliximab or adalimumab. So that's the reason why we have quite a lot of etanercept, because when you look on the younger patients in the registry, etanercept is like extremely low number, to be honest.
And is TB a problem in Czechoslovakia now? Is the TNFs have an issue with TB?
Fortunately not. We are like a low TB risk country in Czech Republic. To be honest, in like 2 years, because of the war in Ukraine, we have a lot of Ukrainians in Czech Republic. It's like over like 500,000. So in this population, the tuberculosis is much more common. Fortunately, we don't see any significant increase in the Czech population in the last 2 years. So we still do in these patients regular, like every once a year, tests for tuberculosis. But for the younger patients or for the patients who are using IL-23 or IL-17 blockers, we don't do this anymore because we don't see any reason to do it.
And just on the back of the paper, number needed to treat to get one person to meet your outcome was about 1.5. And the number needed to harm and get a serious adverse effect was about over 50. So these drugs are very safe in these patient populations. And I think you've taught us that they're just as safe and just as effective in the elderly as they are in younger patients, which is very important. So any other take-home message for the clinician from this particular study, and then where you're going to go next with it?
I think the take-home message is, for us as physicians, we don't need to treat these elderly patients some different way than we treat younger patients. That we see that really the safety profile and the efficacy, it's similar. It's the same for the clinical trials. So don't be scared to treat the patients with the newer drugs because they are more effective mostly. And the follow-up of the patients, I think, still should be the same for the younger patients. I think we don't need to check up these patients more often than we do it for the younger patients. So the take-home message is, when we treat the patient with biologics in monotherapy, it's quite safe. It can get a little bit complicated, as you told before, when we add some systemic treatments, which can be tricky in these elderly patients. And for the future directions, I think maybe it's a time for like the health agencies to try convince the pharmaceutical companies they need to include these elderly patients in their clinical trials, because the population is going older and older. We see it in our population. We see it in our registries that the average age of the patient is going up and up. As well, the patients are starting their treatment in their 40s and 50s, and because they are on treatment for 10, 15 years, they already reach the elderly age right now. So it's important to have these data from the clinical studies. So I think the future is really to say, okay, we need, even in clinical trials, to have like at least some proportion of these elderly patients, because they are a large pool of patients we need to treat from the start. We can't wait for a few years to have like real world evidence in these patients.
So thank you very much for your time, Filip. Greatly appreciated. If you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available imidforum.com. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let us know what you think. You can watch us on YouTube on the Immune-Mediated Inflammatory Disease Forum. And finally, you can follow us on Twitter or X, LinkedIn, and Facebook to keep up with all the new immune-mediated disease content coming shortly in 2025. Thank you so much for your time, Filip.
Thank you for the invitation, and have the rest of the day.